Okay, so I and welcome panelists. Thank you for doing this talk with me. I didn't get a chance to talk to most of you, but what I was thinking was I'm just going to go through a little bit about each medication. I'll say who's going to be speaking. Maybe you can introduce yourself when the slide comes up with your name. Tell us a little bit about yourself, and then I think the majority of this is supposed to be taking questions. Does that sound good to everybody? All right. So my name is Kalen Steiner. I'm a senior gastroenterology fellow here at the University of Michigan, and I'm joined by, as you can see, Ben Malamet, Harrison McCabe, Ashley Simone, Ambry Thomas, I think will be on a little later, and Chris Kelley. And so, this presentation is really intended to be an opportunity to talk to patients who are on medications, get their perspectives, see how they feel about the medication, and ask them really any questions that you might have about what it's like to be on that medication. I am going to start with a very brief overview of the different classes, but this is really not intended to be an in-depth talk about the science behind the medications. It's really, I think, intended to be more about the patient experience on these medications. So I'm hoping I'll be a little more of a bystander, but I do want to give a little bit of background about the different medications we'll talk about. So the first medication I'll talk about is one that we actually don't have a panelist today for, but this is Vetilizumab, and this medication binds. Can you see? Is my mouse viewable? Like can you all see that? Okay, so it binds this thing called alpha-4 beta-7 integrin. But essentially, the way I think about this medication is white blood cells float around our body and they travel to different organs and cause inflammation, and they fight infection. For white blood cells called lymphocytes to get into our intestine, they need this integrin, which think of it as a key. So this is their key to get into the intestine, and this medication blocks that key. So it prevents these white blood cells from coming into your intestines and causing inflammation. So a couple things about the medication, the risks, allergic reaction can really be said about any medication that you might possibly take. There's a risk of intestinal infections with these medications. Less risk of systemic infections because it is quite specific to the gut, at least as far as we can tell. It's a newer medication, but so far that's what the data would suggest. And there's a theoretical risk of this progressive multifocal encephalopathy. And that's really a theoretical risk based off of a different medication in the same class. So far, no cases have been described with Vetilizumab that I know of. This is an IV medication. And over here, I just have a couple of the graphs from the Sentinel trials, but you can see that patients on the medications, which are the orange and red line, had lower scores of inflammation than patients on placebo, which is blue. And also, this is how likely the patient was to remain in remission. And the placebo, you can see they're less likely to remain in remission. So the next class is the class of medications that has been around the longest of these biologics, and this is the anti-TNFs, or anti-tumor necrosis factor medications. So TNF alpha is a cytokine. It's a signal that floats around in our body, and it causes inflammation. And a lot of these medications are approved for IBD and also psoriasis, rheumatoid arthritis, which are also inflammatory conditions. So these medications can cause, again, the allergic reaction. There is a low risk, and this was kind of alluded to in other talks as well, of some cancers, melanoma and lymphoma, but again, that risk is quite low. And we do have upwards of 15, 20 years of data on at least 2 of these drugs. And we always have to check patients for tuberculosis or hepatitis B because these medications can reactivate them. Routes of infusion can vary. So Remicade or Infliximab is given via IV. The other 3 medications are given via a subcutaneous injection. And so with that, I'm going to introduce Ben, who is our panelist who is on anti-TNF.
Hi, everybody. It's nice to meet you all. I've been doing this talk for a couple of years now. I really enjoy this portion of P2PEP because I hope it can kind of give everybody who might be contemplating switching to a new medication, a little bit of an idea of what it might actually be like to be on those medications, so that when it comes time to maybe have that discussion with your doctor about changing a medication, you might feel a little bit more comfortable doing so. One thing to note, though, just kind of going off of Dan Sharp and Dr. Bishu's talk right before this, is that our experiences are representative of just us and our own, an N of 1 for this. So, we can't guarantee that anyone's going to have the same experiences that we do on, all these medications, but we hope that this will be really helpful for everybody as well. So how I came about being on an anti-TNF, for years, I've been having kind of on and off flares of my IBD. And it wasn't really that well controlled. However, for me, I kind of had this fear of being on any medication that would alter my immune system, anything that would require getting injections or going in and getting an infusion through an IV. I was really hesitant about kind of having to go through any of that. However, eventually I got myself into a really big flare where I really didn't have a choice at that point. I needed to try something new because it was just getting worse and worse and worse. And I ended up having a conversation with my doctor about the anti-TNF medications. The two major ones being Remicade and Humira. There's also some, they're called biosimilars, kind of like a generic version of these drugs as well. But for me personally, it came to talking about either Remicade and Humira. Remicade needing to get dosed less frequently, but you'd have to go in and get an infusion of the medication through an IV into your arm. And the Humira being a medication that I kind of would have the option to inject myself at home. So for me, I was able to check with my insurance, and personally, I chose Humira. Reason being is that I was a little nervous, but I felt comfortable being able to inject myself with the medication at home. Some people, they think of that idea and they go, no way, I'd rather go in and get the infusion. But for me, with kind of my busy lifestyle, Humira really was the right choice for me. After getting started on the medication, what actually happened was Humira brought a nurse to my house from the company, and they were able to teach me how to inject the medication. So for the first time I was dosing my medication, I had someone there with me, a nurse, who showed me how to do it, made sure I was doing it right. And then they also followed up with me for the first kind of couple doses that I had due. So I'd kind of get a phone call and say, hey, it's time for your next dose. How are you feeling about it? Do you need any help with it? And Humira kind of provided a nursing helpline that you could reach out to as well, which I find pretty helpful. I haven't had any issues where I've kind of needed to reach out to the nursing helpline. One time I actually didn't inject my medication properly, and I ended up just kind of, instead of injecting it into myself, kind of squirting the medication everywhere. And that nursing helpline was really helpful because they were able to work with my doctor to get me kind of a rush ordered medication out to my house so I wouldn't miss my dose. So they, can be pretty supportive as well. They provided me with stuff like sharps containers as well. But for me, I did have kind of all this fear over having to get an injection or go in for an infusion. I really didn't want my kind of life to change in that way. I was really nervous about having to inject myself. And as I look back on it, I really can't believe that the fear of giving myself an injection or getting an infusion really stopped me from trying one of these treatment methods. Because for me, it really gave me a lot of my life back by being able to have my disease under control. So I guess my one lesson that, I would hope to share with everybody is that, I know that the injections and infusions can seem pretty intimidating and scary, but for me, just being able to kind of get control of my life again had made it so worth it. I was able to go back to eating some certain foods that used to be triggers for me. I'm also pretty busy myself, being a medical student, and have been able to deal with the stresses of being in graduate school. and dealing with IBD because my disease is more well controlled. And yeah, so overall, you know, I'm happy I was able to make the change, and I'll give it back to Dr. Steiner.
All right, thanks, Ben. We're much appreciated. So the next class of medications we're going to talk about, or I'll introduce you to some patients who are on them, are the IL1223 inhibitors. And there's currently one of these medications approved, and that is Ustekinumab or Stelara. There is also, we have a patient here who is in the clinical trial for one called Risankizumab, also called Skyrizi. And these bind to different cytokines. So Ustekinumab binds or blocks IL-12 and 23. Risankizumab is a little more specific. It only binds to IL-23, and it stops those cytokines from causing their pro-inflammatory effects. These really have very similar side effects or risks, no, I shouldn't say side effects, risks as the other medications we've already talked about. So Ustekinumab is given as an IV infusion once and then subcutaneous injections after that. I think how Risankizumab would be dosed is kind of contingent upon some of the studies. It's given subcutaneously for psoriatic arthritis, which it is approved for. Most of the clinical trials for IBD or Crohn's disease, it's currently being given IV, I believe, but maybe some of our panelists can talk about what they've been told or how they've taken the medication. So first, I'll introduce Harrison McCabe. He is our patient who is on Stelara, and he also let me know that he has been on Vetilizumab in the past, so I think he can maybe speak to both of those. So I'll go ahead and pass it to Harrison.
Hi, I'm Harrison. I'm a student at University of Michigan. I'm actually the president of the Crohn's and Colitis Student Initiative, and I have been on Stelara for about 3 years, and I've been on Entyvio in the past, so I can talk about that as well. I am pretty much a non-traditional patient. I have ulcerative colitis. I was diagnosed with ulcerative colitis. It got bad pretty quickly. A bunch of medications failed. I got a J pouch, which also has failed. So I've been on I've had a temporary ostomy for about the last couple of years. That's diverted, so hopefully I can come back one day. So I take the Stelara to help with the inflation, so I can eventually have the J pouch reconnected. So Stelara I've been on pretty much since I got my last surgery, and it's one of these. You get an IV one time. It's about an hour-long infusion, so which beats the Remicade infusions when I was back when Remicade infusions were like 4 hours long. So using that as my reference point, it was awesome. And by the way, Entyvio infusions are about like 30 minutes each, so not bad at all. But the Stelara infusion, no big deal. And the injections, I was scared a bit about having to use a syringe to inject me, because I remember when I was in Humira, it was this pen where you just click it down and it goes right into your skin. You don't even see the needle. But for the Stelara with the syringe, I see the needle. So I was scared about that at first. I was scared about the pain. But to be honest, I like the injection more than IV or even more than a pill, because I do it once every 4 weeks, and generally, it's not just 4 weeks, generally people do it every 8 weeks. So I do it more frequently, and I still like it more. And when you get a shot, it's like pretty much goes straight into your muscle. Like pretend this is a muscle, pretend this is my leg. It goes straight into this will go straight into my muscle. But when I do Stelara, you inject it at this different angle, and it hurts. I barely feel a thing, and I only have to think about taking medicine for about 3 minutes a month to help keep my IBD under control. That's pretty good. You call them the day ahead, make sure everything's set. They ship it overnight in this frozen package. So you open it, make sure it's refrigerated, and they give you a sharps container, they give you alcohol swabs. You rub the alcohol swabs on the area, you inject yourself, which is scary at first, but it's something where you inject yourself, and as soon as you're done and you let go of the needle, it retracts back into the syringe. So it's very safe. You don't have to worry about any sharps being exposed. And they also, like I said, they give you the sharps container, and that's helpful as well. So I think it's been going pretty well. When I was on going backwards a bit to Entyvio, since nobody else is here to talk about it, I was on it not too long because it made absolutely zero difference, to be completely honest. But again, that's only representative of my experience. That's not representative of everybody's experience. And I got a couple rounds of IVs. Again, like I said, they're about half an hour long, so it's not too bad. And the process of that was pretty good. But again, I like the injections better personally, which is why part of the reason why I'm on Stelara. So I can definitely make a good argument for why injections are the way to go. So I think Stelara's been working well.
Excellent, thank you, Harrison. And now I will turn it over to Ashley Simone, who is on Risankizumab in a trial for us.
Okay, yep. So my story is a little bit different. I was diagnosed when I was 13, so I've been on biologics for a good portion of my life. I was on Remicade for 7 years, and then Humira for a short period, and then Stelara for a little bit longer, and then Entyvio. And so far, Remicade obviously worked the best and the longest, but my body just kind of stopped responding to it. So we went through the other meds, and then I came to this trial, and I've been on it since December. And basically, you do the induction period. So I had an infusion every 8 weeks, and I had about 4 infusions. And then you do the 12-week, the post-induction colonoscopy to see like if it's improved, if it hasn't improved, and then you can either go through an induction period again, or you move on to the maintenance phase. And I happen to move on to the maintenance phase, which is the subcutaneous injection. So every 8 weeks, I get 2 subcutaneous injections. And like mentioned before, it's double blind, so I don't really know like anything about it, like if I got the drug, if I didn't, what the dose is, etc. And so far, it's like a pretty good experience because I feel a lot better than I did in fall 2019. So yeah, I think that I like this one. This one worked just as well, I think a little bit better than it did for Stelara if we had to compare the same drug class. But yeah, that's it.
Excellent, thank you so much. All right, so the last class of medications that I'll briefly talk about are the JAK inhibitors. So JAK stands for Janus kinase, and this is basically just another signaling system that our body uses to regulate inflammation. And this is a really active area of research as well. There is one medication that is out for use in IBD, and that is Xeljanz, or Tofacitinib, and that's approved for ulcerative colitis. This medication is actually an oral medication, so unlike the other medications we've discussed today, this one you actually take as a pill. Some risks of this medication, they're a little different than the other ones. So this can cause infections just like any immunosuppressant, but this medication does have a higher incidence of shingles than the others, as well as diverticulitis. So it's really important if you're on this medication to be vaccinated for the shingles, or get the shingles vaccine. And there's also a risk of blood clots with this one. So it's a little different than the others. Again, the route is given orally. There is no induction that's IV. You just start on the medication. And to the right, again, I have some of the graphs. Upadacitinib is a clinical trial medication. This is currently approved for rheumatoid arthritis, but is being studied for ulcerative colitis as well. And that's a graph from a recent, the bottom is a graph from a recent phase 2 study. So the panelists we have, I think we're still waiting on one that might not be able to make it. That's Ambry Thomas. But I'm going to introduce Chris Kelley, who is on Upadacitinib.
Hi, everyone. Glad to be here. And also, all the other presentations have been great. So I want to thank all of those speakers because I'm certainly learning a lot today as well. So I was diagnosed with ulcerative colitis about 7 years ago. And like many others, I've just gone through multiple medications where I'd get some short-term relief, but then my body just stops responding. Then I have to go back on the steroid for a little bit to control flare, find a new medicine, works for a little bit, back on steroid. So I was going back and forth quite a bit. And then I started doing some clinical trials. So the UPA is actually my 3rd clinical trial I've been on. One of them was mentioned earlier to the Etromizumab Vetilizumab one. I think that's how you pronounce it. So I was involved in that one for a little bit, but again, I just wasn't responding to it. I will say the UPA being a pill, it's been quite nice compared to the infusions or even the injections that I got before, because I just made a daily routine. As soon as I wake up, I brush my teeth, take my medicine, and that's it for the day until later that night. I just have to log on the e-diary. So it became really easy to make it a habit. Thankfully, I've been responding pretty well to the medication. I will say the best thing I can say about it is kind of maybe forget about my UC a little bit. It's because I've been responding so well, and I've kind of gotten back to do some normal things and just feeling better. So, but it's been going well. I haven't seen too many of my symptoms come back, or they're all dialed down, but I still keep the UC back in the back of my mind, and it's just glad that I can be off the steroid, because obviously long-term effects of the prednisone use is not good. And I haven't really seen any of the side effects. It's pretty manageable. The really only other change I've had with UPA is to avoiding grapefruit, which wasn't hard for me to do before anyway, because I didn't really eat it. I mean, there's a couple of good beers that have grapefruit in it, but of course alcohol is not good for the UC, so I wasn't really doing much of that anyway. But I would say the UPA has been really good. And again, Dr. Higgins and the rest of and like Jen Dixon there have been amazing to work with, with the clinical trials. So, and all three of them I've been with, they've been very helpful, answer all my questions, and just make it really easy to try this medication to see if it might work for me, which this one finally has. So I can't say enough about the team at U of M and the clinical trial experience I've had.
All right. So thank you very much. Dr. Higgins, we can't hear you currently.
We just have a few questions coming in. It looks like Mr. Thomas is trying to join in. I'm going to see if we can get his webcam on. I'm not sure why, but he's going to keep working at it. In the meantime, I'm going to try a few questions. Are any of the patients today dealing with perianal Crohn's disease and fistulae? If you have, at any point in time, which meds work the best for that for you? No, none of the above, I'm afraid. Okay, well, that's good for you. In general, probably our best evidence is for Infliximab, well, Remicade and its relatives, Adalimumab or Humira, and Ustekinumab or Stelara. Those classes seem to do the best for perianal disease. That question was from Cynthia Freeman. A question about, do any of you have arthritis along with your IBD, and did any particular therapies work well for that? Yeah, nothing. Okay.
No arthritis for me.
Okay. As a general rule, the drugs that are also approved for arthritis, like Tofacitinib or Upadacitinib, tend to work well. Stelara and Skyrizi are approved for psoriatic arthritis, so that's reasonably likely to work well. We also sometimes use methotrexate, although that's not a good option for young women who might get pregnant in terms of arthritis options. Okay. Question, why would you choose infusion instead of a tablet every day? What's your kind of pros and cons for each of you?
I can go first.
Okay.
So since I grew up, basically, I had 7 years of Remicade, so I got infusions for 7 years, like every 8 weeks or so. And so, I mean, for me, it was kind of like something you could look forward to when I was a little kid, because I got to miss a half day of school. And I always got like a treat with it, because like my parents would give me something like So I look forward to it in a sense. And so, but now as an adult, it's even like, I don't know, I guess maybe because I grew up getting infusions, I'm not uncomfortable with it. So, I mean, I kind of have like, I have a trouble swallowing pills sometimes. Like I have to cut them in half because I just like, I don't know, I have that fear. And so I think like it's kind of, my situation might be different because like I don't mind like needles and infusions, but that just might be my personal experience.
Sure.
I'd say mine was a little different as well. For me, the pills that were available to me kind of had stopped working. So for me, I really didn't have a choice to go to another medication that was in a pill form. So I was kind of limited due to I'd run out of pill form options, and also my insurance wouldn't cover possibly like a drug like Xeljanz before I had been on the Humira. That's just kind of my own personal experience. So I kind of didn't have much of a choice in the matter, but I did have the choice in whether I would do injections or an infusion. But at the same time, you know, I would say not to be afraid of the injections or the infusions. There's really great support out there for kind of going through that experience and learning how to, you know, either self-inject or, you know, having spent time with some of the infusion nurses in the past, they're absolutely amazing and very supportive as well of you going in and getting your medication too.
Okay. Harrison, your thoughts on choosing infusion versus injection versus tablets?
I think the thing with tablets is that I take tablets for other conditions, and sometimes I forget to take them or forget to take them where I just don't want to take it. And that sometimes I'd worry about that with an IBD thing because I'd worry about its effectiveness if you're not great about taking your pills all the time, whereas it's a lot harder to forget something like an infusion because you'd schedule it out in advance. You get a lot of email reminders. And when it comes to injection, a lot of times I just think about like what's the least amount of time I'm spending with the medicine. With drugs, I'd give it about a minute per day, whereas with like an injection, I'm giving it like a minute, like 5 minutes every month or two. So just not having to think about it that long is really turn on for when it comes to injections.
Great. One of the theoretical benefits of the oral medicines is you can't make antibodies to them. So in theory, if they work for you, they work for you for a really long time. Although Sarah Ringer comments, I am the worst at remembering oral meds every day. Infusions and injections are so much easier to remember because it's not daily or several times daily. Are you guys pretty much in that boat? Okay. Fair
I
enough.
have to set like reminders on my phone to like take vitamins and stuff, so I would have to just reminder.
I can always ignore the reminders though, which is where forgetting comes in.
There's a challenge to
I
forgetting.
have my medicine bottle next to like my toothpaste and stuff, so I always see it every day as a reminder.
It looks like we may have Mr. Thomas on audio.
Yes, I'm here.
Oh, super. I was wondering if you could maybe just start with telling the story of how you got sick, and you got really, really sick, and kind of your journey with Xeljanz or Tofacitinib.
Oh yeah, I got sick probably like at the beginning of June last year and spent like over a month in the hospital and finally found a medicine that worked for me. And that was the Xeljanz. My body responded to it very fast. I say after a week, the doctors was telling me that my colon's looking better, everything's looking better, and it was progress. And I was kind of stressing myself out because I had a season to get ready for at Michigan within like a month, and I was really worried about the medicine. Like, what if it don't work? Like, what if I get back in remission and everything happens again? Because that's what had happened. The first time I went to the hospital, we got stuff under control, but everything wasn't right, and I had ended up coming back like
Did we lose his audio? I think Mr. Thomas is calling in from Arizona, unfortunately. And we may have lost his audio. For those who aren't familiar with University of Michigan sports, the athletic activity in season he was referring to is college football. It's, for those of you outside the US, it's a surprisingly big deal. And it's a very high level athletic activity. I think, Mr. Thomas, are you there?
Yes.
Okay. Sorry, we lost your audio for a little bit.
Oh yeah. What was last thing you guys heard?
You had just gone back to the hospital.
Oh yeah. I had just gone back to the hospital. Was trying to figure out the medicines that worked for me, and Xeljanz was the one. Picked up on it immediately, and my body started like responding, and I got back in recovery, and I got back in time for the first game. So that was a good thing on the Michigan doctors for getting me back just in time. And yeah, I like the Xeljanz a lot, honestly.
And how do you work at remembering taking the tablets? Because a lot of people in the panel, the other patients, have commented that it can be pretty hard to remember.
I mean, how I look at it like my body is my business. So if I'm not right, then if my body not right, I'm not right. So if I feel a little bit nauseous in the morning, I used to get like a nauseous feeling in the morning. And once I feel that, I immediately go take the medicine, and the nauseous feeling will go away. And I'm like, all right, that clearly has something to do with that. So yeah, I used to get those little reminders, but now it's just like I take all my other vitamins and I take my medicine at the same time. So it's just like we knock it all out at once and go about our day.
Yeah. Now, if I recall correctly, you lost a lot of weight and then had to put back on a lot of muscle for the season.
Oh yeah.
What kind of numbers are we talking about?
Oh yeah. When I went into the hospital, I weighed 187, and when I got in the hospital, lowest I got to was like 144. I almost cried. I'm like, oh, it's like 3 weeks before the first game. I was worried about that, but yeah. Once I got back out the hospital, I was on the prednisone and the Xeljanz at once for a minute, and I picked up my weight, and I left the hospital at 193.
It's great. It's great. Okay. We have another question for the panel. As someone starting a biologic for the first time, how would you recommend handling difficulties with insurance? Who do you contact first, your GI doctor or the pharmacy? Have you ever had to handle a situation where you needed a next dose, but insurance isn't ready to cover it? And this is for any of you four.
I personally have been pretty lucky, having been a patient and still am a patient at University of Michigan. Their staff was really awesome about making sure that the prior authorization form had gone through and made sure that, you know, I was being approved for the medication. For some of you that might not know, a lot of these medications, once they are so expensive, require something called a prior authorization form from the insurance company. So what that form does is basically it's filled out by your doctor, goes to the insurance company that basically says, hey, Ben really needs this medication. You guys need to, you know, give him this medication. So for me, that involved just kind of checking in with the doctor's office, but they were 100% on top of things, but also checking in with my insurance company, calling them up and saying, you know, hey, you know, when is this going to get approved? You know, my doctor submitted the form. You know, do you guys have it? And I was lucky that I, you know, was approved for Humira. I don't know if anyone else on the panel has experienced denials. But as far as how I was able to check in and make sure, it was just calling the insurance company and making sure that they were working with my doctor's office in a timely manner to get me the medication that I needed.
I had a denial where I think I was trying to get approved for Stelara for my UC, and it was denied as an experimental for colitis. So we went through an appeal process with my insurance company that fortunately, it still didn't get approved, but you know, that was something that I think my provider did on my behalf. So that's kind of nice of them to do. But yeah, I work in health insurance, so I know there's a lot of agreements and appeals processes that can be used, especially when it comes to like a medical judgment. So I would encourage anyone, if you do get a denial, certainly explore those avenues with your insurance company, because generally speaking, you could, if the denial goes far enough, it does get reviewed by an independent review panel of doctors. So I encourage just exhausting that process as much as possible.
Great. Other just kind of big picture perspectives from anybody on the panel in terms of how you go about choosing a medication or discussing what your choices are, whether with your doctor or with your insurance?
I could definitely kind of speak to that a little bit. I'm also a member of the Crohn's Colitis Foundation's Patient Advisory Board, so I'm going to give a little bit of a plug to them to kind of check out the resources that they have online, so that when you do go to your doctor's appointment or after your doctor's appointment, if you want to find out more about a treatment method that your doctor has recommended, you know, get educated, learn about these medications so that you can feel kind of more empowered in taking them, knowing how they work. I think it's a really cool thing, and it also kind of helps me stay, you know, it helps me take my dosing, knowing exactly kind of how the medications work. Dr. Higgins and the University of Michigan's IBD team has a wonderful YouTube video series as well called IBD School, and they go over a lot of these medications as well. So just encourage you to kind of increase your understanding of IBD and of these medications so that you can feel empowered in taking them. And then when it comes time to, you know, thinking of that next step, and thinking about possibly, you know, upping your treatment regimen to include a new medication, I just recommend having, you know, this shared discussion with your physician about these medications so that, you know, the two of you can come up with a plan that works for you. But also keeping in mind as well that unfortunately we also have to work in line with insurance as well, and what we can, you know, work with to kind of get your medication or get your IBD under control. And I would just also say, just based on my own personal experiences, you know, I had a lot of fear thinking about going on a medication that I would need to inject myself with, or a medication I need to go in for an infusion with. And, you know, as I look back on it now, I'm so happy I was able to make that decision and kind of move forward with my IBD medication, and keep myself under control so that I can really be living my best life with IBD.
And Chris and Ashley, just from your perspective, was it scary to go into a clinical trial, and what led you to make the decision to do that, to get access to a new med?
So with me, having been through all the biologics I've been through, this is kind of like my last resort before I have to get surgery. So I wanted to try this. And just like with that being said, like Crohn's isn't necessarily something like good. And I thought like enrolling in a trial would be good. Whether or not I respond to it, it like helps further research for future patients. So I went into that thinking like, if it doesn't work for me and I still have to get surgery, I'm still like contributing in a sense to research. And I think that's like one of the like big reasons I wanted to, besides like trying to not have surgery. But yeah, I think that's, and I was scared at first just because it's like something new, but I've been on so many biologics before that I wasn't necessarily scared of like the needles and the infusions and like all the tests that you have to do, but I was more scared of like, will my body respond to this? And if it does, how long like am I going to be able to like have this medication? Because so far I like it, and I've had like a few bumps in the road, but I mean, it may not last forever. So I think that was like what scared me the most, is that it just might not stay forever. But that's why you're doing the trial, to see like how it helps. So I just like that it's helping people and it's Yeah.
I would say similar to Ashley, I just wanted to explore all my options before having to have that surgery discussion. I was personally, I'm fine with getting infusions, injections, or needles. I don't have an issue with them. So again, I just wanted to explore all my options before surgery. And I was definitely nervous about it being, a clinical trial, kind of considered an experimental drug, so not everything's in my head, like not everything's known with it. So I may have a side effect that no one else has had before. And if that happens, how do I deal with it? But so that was like a big nervousness of just some unknowns of what could happen on this drug. But I felt like the benefits outweighed the risks involved for me. So that was something just to take advantage of, and to consider, and just trying to find something that might work for you, and then seeing how long that'll last. And then I feel like I'm contributing a lot of data to the 3 trials I was in, so that way it can be useful for other people too.
Definitely advancing the field. I have a few other things from the comments. Lori Plung suggested we mention the Safe Step Act, which the Crohn's and Colitis Foundation has advanced. It's a proposed law in different states to make sure insurance companies don't kind of drag their feet between each step, and that each step in step therapy is a rational, approved therapy for IBD rather than just something they pull off the shelf. Sandra Zielinski mentioned, particularly for people who have an ileostomy, and especially a high output ileostomy, and they don't absorb oral medications well, that is a really good reason to choose an injectable or an infusion instead of an oral medication. And somebody mentioned, I can't find the name, that a couple of the current oral medications like UPA and Tofa, unfortunately, are associated with blood clots, and that's sometimes a problem with certain patients with IBD. If you've had blood clots in the past and you're not on a long-term blood thinner, these aren't a great option for you. That being said, if you've had several blood clots and you are on a long-term blood thinner, that may make it reasonable to add these meds. And before we move on to the next presentation, I wanted to shout out to Mr. Thomas. We are rooting for him to make it big in the NFL in the fall, assuming they're back next year. And great. How are your preparations going?
Everything's been going pretty good. I'm out here in Arizona right now training.
Great. Yeah. With the cancellation of the season, which is now sort of back, Mr. Thomas went pro early, and hopefully he will be very successful next year. I want to thank all of you for participating and giving each your perspective on different therapies for IBD. There may be more questions. We'll try to get you guys a chance to answer by text, but we'll do what we can. And I think now we're going to move on. And I think Dr. Steiner, you're part of the next presentation as well.